Hello. Today we are going to speak about syndromic craniosynostoses and how they are managed in pediatric neurosurgical practice. So how do we define a syndrome? A syndrome is a group of symptoms that consistently occur together, or a condition characterized by a set of associated symptoms, and we can add and lesions. So we now tend to define the syndrome by identified mutations, which is especially interesting in fasciostenosis. We are more and more identifying the genes associated with fasciostenosis. We also have chromosomal anomalies, which are sometimes microdeletions. Then we have to analyze which genes are involved and how they can be related to the phenotype. And we also have syndromes associated with environmental causes, like in trigonocephaly, for example. And also we have some associations of malformation which are not known with a private name. So they are what we call orphan diseases. And sometimes we have familial conditions with no gene identified. So there is much room for research, as you can see. And we also have unexpected outcome of monosutural synostosis. So we have to follow these children and be aware that one trying can hide another one. So the syndromes were identified initially on rather straightforward, as we can guess now, from the classical definitions by Cruzon and Appert, with calvarial stenosis, mid-face stenosis, and in some of these syndromes, anomalies of the hands, of the ears. And it was the merit of Cruzon to point out that these malformations were genetically determined, and more and more genetics has taken importance, and it is a little bit the genius in the bottle. And when it is out of the bottle, very strange things are appearing and making things more and more complicated for us to understand, because we have the same phenotype with different genes. We also have different phenotypes with the same genes, and this is especially the case for the FGFR gene family, which can cause the Pfeiffer syndrome, the Appert syndrome, the Cruzon syndrome. And according to the mutations, you can have different phenotypes, but also with the same mutation in one family, you can have much variability, because the mutation combines with other genes, and there is much variability inside the families. So we see that we don't have watertight categories. We have to accept this challenge to our understanding, and also we have to integrate in our knowledge the new mutations and the variants, which relation do they carry with the synostosis we see. There is a lot of work to be done. So there were some nosology discussion at the start of the description of these syndromes. This is in French. This is verbatim from a meeting of surgeons in Paris. This is a translation thanks to Google Translate. And we see that Octave Cruzon was already conscious there was much variability in the phenotypes of his namesake malformations, but also Appert, who had described the craniofaciosynostoses with syndactyly, had also noted that some of patients have minor malformation of the extremities. So there were also already a guess that some of these Cruzon malformations were Pfeiffer syndrome, but Pfeiffer syndrome was to be described only 27 years after this meeting in Paris. So the different phenotypes, we have craniofaciosynostoses, of course, which are all identified syndromes with Cruzon, Appert, Pfeiffer, and so on, with all these telltale anomalies like the syndactyly, the big two and thumb, the ear malformation, and so on. But we have also craniosynostoses in other syndromic contexts, especially bone metabolic disorders like Albright syndrome, osteopetrosis, and so on and so on. And the list is not closed, of course. But we have also isolated craniosynostoses, which are caused by syndromes, we shall see. In schistocephaly, we have up to 10% of patients who have some genetic anomalies, which are sometimes variants. We have to guess what importance they have. In trigonocephaly, as we shall see, we have 30% who are syndromic, often not genetic, but syndromic. In unicoronals, about 30%, more than 70% rather in bicoronal synostosis, also in lambdoid and in oxycephaly. So all these craniosynostoses asks the question whether this is syndromic or not. What about bicoronal synostosis? We understand that it is a minority, it is shrinking. In this rather a little bit unsigned series from Lille, we had less than half of the bicoronal synostosis which were considered non-syndromic. As that means genetic conditions were identified in more than half. But if we look at the other form of syndrome, that is familial disease or association of malformation, we have only less than one third of bicoronal synostoses, which are in fact not syndromic. So it is a provisional by default entity, and we see that there is a historical trend according to the year of diagnosis. The proportion of syndromic bicoronal synostosis grows decade after decade. Now, schistocephaly, we have to follow them, as I said, because there can be a delayed closure of the coronal suture, about 1 or 2%. That means it can be unilateral evolving to plagiocephaly or bilateral evolving to oxycephaly. And so, as I said, one train can hide another one. And this is another example. And we have also delayed closure of the lambdoid suture, which gives rise to the Mercedes-Benz syndrome. And we also have some associated conditions with dystrophic, metabolic disorders, and so on. So again, this is there is room for research, and we have to be aware of the higher prevalence in girls, who represents only 1/5 of the schiphos, but have a higher risk of syndromic synostosis. Unicoronal synostosis, about 11% are syndromic. They can be FGFR mutation, twist, or TCF12 mutations. But they can also be associated with other synostoses, as said before regarding the sagittal, and we can very often the syndromic plagio evolve to asymmetrical brachycephaly, like in this case. The metopic synostosis can be associated with a syndromic context in about 1/3 of cases. It is more often environmental, classically the valproate syndrome. Also, ethanol can give metopic synostosis, but it can be also chromosomal. So it has an influence, of course, on the development of the child. It can be genetic, associated with other genes, like in particular twist gene or other genetic conditions, and it can be familial, but without identified mutations. It may be that the father and son are submitted to the same environment, but it is more likely that there is a genetic underlying condition. The lambdoid synostoses are often syndromic, and especially if it is in the situation of multiple synostoses. It can be associated with the classical genes of other synostoses. In our series of 31 cases, 12 of them had these genes. It can be associated with a metabolic disorder, as I said before, of the bone metabolism. It can be a chromosomal disorder, and can be associated with other mutations, like in this Alagille syndrome. So to summarize, we have the classical concept of the different classical mutations identified long ago, and we have associated with bicoronal synostosis, unicoronal, sagittal, metopic synostosis, very few of them, but it happened, and more often lambdoid. And we have to extend the concept of syndromic in genetic mutations, as I said before, but also chromosomal, phytotoxic, bone disease, familial disease, And in this case, we have much more often a syndromic context, especially in sagittal and metopic synostosis. So we have to, it has some interest to propose systematic genetic screening like we do in our team and has been published this year. Then now the genotypes, we have the classical Cruzon-Pfeiffer syndrome, because we now know that these are in fact the same disease, and these are caused by a variety of mutations of the FGFR2 gene. It gives more or less obvious malformations of the fingers, especially the thumb and the big toe, which can be seen prenatally. And basically, a Cruzon syndrome is a Pfeiffer syndrome not properly examined. That means the socks have not been removed. But basically, it's the same disease. We have a craniofaciosynostoses with a facial protrusion. We have a high tendency to skull-base stenosis with tonsillar herniation. So this is the Cruzon-Pfeiffer syndrome. Now we have the Eipert syndrome, which is associated with other mutations of the FGFR2 gene, which has the same sort of craniofaciosynostoses, which can be diagnosed prenatally, and in this case it was very severe and not viable. And the severity of the Eipert syndrome is associated with synostosis, which can be very severe, as seen on the left, and it can be membranous or osseous, and sometimes associated with elbow or knee ankylosis. So, and it impacts the neurodevelopment of the child. Now we have the Cruzon with acanthosis nigricans, which is a different disease due to another mutation of the FGFR3 gene. It gives this kind of skin disease, which can be a problem if you have to implant a shunt because the skin is not very clean. But it is associated with the same craniofaciosynostoses, with skull-base stenosis. And you can see your patient becoming grayer and grayer year after year. Now we have the Muenke syndrome caused by a mutation of the FGFR3 gene, which causes a mutation of the change of the 250 proline to arginine, and it gives isolated bicoronal synostosis. So it is a by default cause of bicoronal synostosis, which appears isolated, but it also causes deafness. So it has to be looked for even before the genetic result has been obtained. Now we have the Sartre-Schozen syndrome, which is another gene associated with craniofaciosynostoses, with a fasciostenosis, but also ptosis, a low hairline, and a telltale earlobe malformation, which is called the crux-simbe, and also anomalies of the fingers and toes with a syndactyly of 2 and 3, and brachyd metacarpia of the fourth radius. And it is also associated often with a persistent parietal foramina, like in this child, and sometimes it can cause metopic synostosis. So we are progressively diversifying the phenotypes of these mutations. Now we have the TCF12 gene, which gives a twist-like phenotype with a bicoronal synostosis, low hairline, abnormal earlobes, but this is not the crux-simbe we have in the twist mutation. And we have published a paper in Lille showing the high prevalence of earlobe anomalies in TCF12 mutations, which helps to the diagnosis. Now we have the ALX4 gene, which is a homeobox gene, and these are twins who were affected. One had a purely sagittal synostosis, while the other had a Mercedes-Benz syndrome. And this is another case with the same mutation, and he had a metopic synostosis and foramina parietalia per magna, like his mother. And he also have a nevus sebaceus. So you can see that with this mutation, we have a large array of different anomalies, which are in relations with this mutation. And this is a patient who had a double variant, ALX4 and TCF12, and he has both a SCAFO and a hydrocephalus, while his brother, who had only the TCF12 variant, had hydrocephalus. So it is, we have to think about such cases where we have variants which are identified. We don't know if they are pathogen. We don't know if one variant can become pathogen with a modulating other variant. So as you can see, there is much room for research. A new gene which has been described recently is SMAT6, which can cause metopic synostosis, sagittal synostosis, oxycephalic malformation, and is also by itself a cause of developmental delay, as shown by our psychologist in our team. So as you can see, we can have a genotype-phenotype variability, which is more and more important as we discover more genes, because the most obvious gene mutation has been discovered long ago, and now more difficult things are to be found. We have the correlation with chromosopathy. We have the trigonocephaly can be caused by this gene. So you see that you have different phenotypes with the same gene. You can have different genes with the same phenotype, and you have a lot of variability in the genotype-phenotype correlation, and certainly the list is not closed. This is an example of a family with a mutation of FGFR2, and you have different phenotypes. Some of the members of the family had just a maxillary retrusion. Others are severe craniosynostoses and faciosynostoses, and it could affect the sagittal, the lambdoid, the coronal. So the phenotype was very variable among this same family. This is another family with a twist mutation. And again, we have a very variable phenotype from one person to another, with some very mild phenotypes with ptosis, but the mutation is the same. So that means that the expression of the mutation depends on the other genes present, because the genetics setup is different in all individuals. So once we have made the diagnosis, we know that we have to propose a multidisciplinary long-term management. And in the prenatal diagnosis, sometimes the diagnosis may be missed if there is no indications of a familial disease by ultrasound. When we do diagnosis, we do an MRI to look for hydrocephalus, to Chiari, to other lesions. The fetal CT scan can be very interesting, especially to study the extremities and the face, because here we had a synostosis, radiocubital synostosis, which was indicative of Antle-Bixler syndrome. Then we have to conceal the patient, the family. If there is a severe faciostenosis, we have to inform that the child may be not viable. And we have to anticipate the breathing problems at birth. That means that the birth should be programmed close to the craniofacial center. And we have to think about the risk of recurrence. So we have to check the father and the mother and look if there is a high risk or not of recurrence for further pregnancy. Then we have the neonatal management. We have to, we can have a problem with the airway, which can be helped if there is a palatine cleft. If not, we may need to do a tubinectomy, sometimes a tracheostomy, or an early distraction in order to improve the airways. But the question is whether the child will be viable or not. And this one on the right did not survive, unfortunately. Then we have the feeding problem. The patient may need a nasal tube or a gastrostomy, and sometimes this feeding problem can be aggravated by the tonsillar herniation, like in this newborn who had a stasis of the esophagus and stomach. And there may be brain compression and vision problems. This is an example of a newborn who had to be operated at day 9 of his life because he had severe hypotonia, eating and breathing difficulties, and we did a posterior linear craniectomy, and he was markedly improved. So we may need to operate a little bit later by linear craniectomy. It can be a perifrontal craniectomy, which improves both compression and shape, or posterior decompression. We can help by providing venous decompression, or we may need to do both in different stages. In most cases, we do later surgery, if possible, around 9 months, to do brain decompression, to improve the morphology, as you see in this child on the right, on top before surgery, below after surgery. You see that the mid-face protrusion improves markedly. So, and of course, to improve function of vision, breathing, and feeding. The management of fasciostenosis can be isolated if it is an isolated fasciostenosis. This is a technique of distraction which was proposed by Professor Pelham a long time ago. This is how it was perceived by one of his patients, with Professor Delem, my mentor associated, and the psychologist. And it gives this kind of results. And we can also do facial advancement. Lefort 1 is airway is sufficient, or Lefort 3 with distraction osteogenesis, or monoblock Lefort 4 osteotomy. So this enhances the impact of the Lille institution in this surgery. This is the results on morphing done by Professor Pellerin, the CT scan before and after, and you see that the airway is improving very fast after craniofacial distraction. The hypertelorism can be a difficult problem. It can be improved when we do frontal-orbital advancement by overlapping the frontal flaps and both hemibandos. It improves the shape, but it can also be a little bit improved when you do parietal flaps, which can be asymmetrical with a larger transverse diameter anteriorly and posteriorly. That means that when you advance the flap, it reduces the coronal length. And in the most severe cases, we may need to do a facial bipartition, which is a huge operation, but can improve very much the outlook of these children. And we also have hydraulic problem, which can take the form of pseudotumor or hydrocephalus, and it can be caused by venous encasement in the bone growth. So it may require craniectomy, which can improve the situation, as seen on the right. It may be caused by atresia of the jugular foramina, in which cases we don't have much things to propose except chance. But chance will stop the calvarial growth. And we have, of course, downward herniation of the cerebellum, which can cause progressive Chiari malformation, like in this child. So we have to make a choice between expansion cranioplasty, posterior or anterior, or posterior fossa decompression, or shunt. So these are a complex decisions to be made. And this is an example of a child with a Crouzon who had a shunt. And when he obstructed his shunt, you see the orientation of his internal auditory canals. And with the downward pressure, he had facial dysplasia, certainly due to a downward traction of the facial nerves. And this is the same patient who had with these images at birth and a few months later, and the different operations he had, and the melanodermia he developed, and he became an adult with active sportive involvement, but he developed spinal stenosis, which is one of the ailments that we can see in adulthood in this patient. So this is really a lifelong commitment. So the messages are that we should always think about syndrome, even in monosutural synostoses. Syndromes can be genetic, chromosomal, environment, familial disease or associated malformation, which are often diseases. And we published the results of the systematic genetic tests in these patients. When there is a syndrome, it has a major impact on the viability of the fetus when it is diagnosed prenatally. It has a major impact because of associated disorders, of progressive diseases, reoperations, and handicap. The management is complex. It should be, it is of course multidisciplinary, prolonged, and it should be performed in reference centers for rare diseases, and especially since we have on the horizon targeted therapy, which will probably help avoid complications of these diseases. I thank you for your attention. You can see more videos on craniofacial playlist on YouTube and more data on our website. I thank you for your attention.